Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
After proper anesthesia has been given and the necessary radiographs and study models are available, the preparation is commenced. A 770-7M diamond is used to cut tracer cuts on the mesial, buccal, distal, and lingual of the molar. The purpose of the tracer cuts is to give you a reference of how much to take off of the tooth on these various peripheral surfaces. The diamond is carried into the tooth only 1/2 of its diameter. These tracer cuts are parallel to each other and parallel to the line of draw of the anterior abutment tooth, which is the bicuspid. It is wise to place pencil marks on the tooth when you're first attempting to place the tracer cuts. Then the tooth is reduced in sections. The mesial buccal section now is being reduced, carrying the finishing line just to the gingival tissue and to the depth of the tracer cuts, which is again half the diameter of this diamond instrument. Now the next quarter or the segment of the tooth is going to be reduced, and this will be the mesiolingual, again keeping the diamond instrument parallel to the draw of the anterior abutment tooth, using a high speed and light touch, carefully reducing this area. This then is carried to the distal buccal area. Now here you'll notice that there's a cheek in this particular area, and this has to be held away from the rotating instrument. You will see now that a chamfer has been established on the lingual, mesial, distal, and buccal of this tooth just above the gingival tissue. The next step is reducing the occlusal surface. Tracer cuts are again placed on the occlusal surface, but this time to the full depth of the diameter of the diamond instrument. This again will give you an organized approach to the reduction of this occlusal surface and giving you a standard amount of reduction. Once the tracer cuts have been placed on the buccal and lingual portion of the occlusal surface, then the remaining islands are reduced until you have an approximate reduction of the occlusal surface, which is the diameter of the diamond instrument. The instrument then is turned at right angles, and the line angles are rounded with the same diamond instrument. Here we are trying to be very efficient with the diamond instrument, using it to its fullest ability. Now the amount of occlusal reduction is going to be checked with 2 thicknesses of 28 gauge green wax, and we can check with the indentations of this wax to see if we have adequate occlusal reduction going into working and balancing. When the proper amount of occlusion and occlusal reduction has been obtained, then a retention groove on the buccal and lingual is placed. This retention groove is parallel again with the anterior abutment tooth, and this is placed to resist any dislodgement in an anterior-posterior movement of the tooth in occlusion. A final finishing of the chamfer is placed with a 3/4 A diamond instrument, and this is just a slight beveling of the chamfer to make it sharp and to add just a little tiny lip of gold around the chamfer. This is carried completely around the tooth. The final finishing is done with sand discs mounted on a Moore's mandrel. In this particular case, there are a couple areas of caries on a pit on the buccal and a little bit on the mesial. This will very carefully be removed, and a cement base will be placed in this area. Now, a careful examination of the finished preparation is important to see that we have all the details, that we have a line of draw, our finishing line is smooth and is carried under the tissue properly, and that we have enough occlusal clearance. Then we're ready to proceed to the preparation of the bicuspid. A 699-9L diamond is used to do the initial cutting and slicing. Here, it's very important that we do not nick or cut the adjacent tooth. So great care has to be taken with the handling of this rotary instrument. And using a light touch, very carefully entering the proximal surface, you can open up this area, slice it, without injuring the adjacent tooth and without giving our tooth too much taper in this particular area. You'll notice that in this procedure there is very little bleeding of the soft tissue if the diamond is handled properly. Now from this occlusal view, you can see the amount of slice that has been obtained by using this diamond instrument. The slice, as you can see, is slightly concave. Now with a 770-7 diamond, the same diamond you used on the molar, a tracer cut is placed on the distal and the lingual surface. This again is to allow us a guide in the reduction of these surfaces. This is carried just 1/2 the depth of this diamond instrument. Now with the same diamond, we will take that remaining area of enamel and dentin and reduce it to the depth of the tracer cut, so that we will have a chamfer established around the lingual surface that will blend into the mesial slice, and a distal slice that will come out to the buccal surface. Great care must be taken to bring this out far enough to the buccal surface so that we have brought our finishing line out far enough so it's in an area of immunity. Now here you can see blending of that chamfer into the mesial slice. Here again, since this is a bulkier diamond, care must be taken not to nick the adjacent bicuspid. You can see the detail of the chamfer. Tracer cuts then again are placed on the occlusal surface of the bicuspid, carrying the diamond to its full depth to give us a reference of how much to take off of this occlusal surface. And we are going to protect this buccal cusp, so we will also extend our tracer cut over the buccal surface. And then when our tracer cuts have been completed, we will reduce the remainder of the tooth to the depth of our cuts. This is to give us enough clearance in waxing so that we do not make the gold so thin that the patient will wear through it. We need enough clearance so that we have enough gold for strength in this occlusal surface. Once you have the tracer cuts placed, the reduction of the occlusal surface really becomes very simple. It's just a step-by-step procedure. You'll notice in this particular case in the mouth that there is tongue and cheeks and saliva to contend with that you will not have on your Visident model. Now we are placing the mesial and distal boxes. This is done with the 770-7, with the diamond held as parallel as possible to the tracer cuts and the retention grooves cut on the molar. You can see now the connection of the mesial and distal boxes across the occlusal. We are traveling through the isthmus, making a box or staple form on this bicuspid. Now further refinement of our surface of protection on the buccal surface, and using a 3/4 A diamond, we are modifying our chamfer slightly to make a definite sharp margin so that this margin can be read readily on our dies, and when you're in practice, a technician will be able to read those margins very easily. Further refinement of the preparation is done with a sand disc to make sure that there are no roughnesses. Now the occlusion on the bicuspid, which is more anterior can be checked visually by having the patient go into working and balancing. When you're happy with the preparations and in our tissue packed, with your Visiodont, you will not have the soft tissue as you will have here, and your finishing lines are above the tissue. This is a very important step in the impression taking in the patient situation. And many rubber base has been ruined by not having the tissue packed properly. You'll note here that there is no bleeding involved with this, and this will give us room to place the rubber base once the tissue has been retracted. After the rubber base has been mixed, the string pack will be removed, usually after 5 minutes, and then the rubber base is injected around the preparations, carefully avoiding any bubbles. The teeth more anterior also are injected, and then custom tray has been fabricated, and this is seated very carefully down to the occlusal stops that you have placed on the former tray. And after the impression has been seated, it'll set there now for 10 minutes until the rubber base has completely set up. The removal of the tray is very important. It should be in the long axis of the tooth, and after the impression has been removed, we'll dry it and examine it. You should examine the margins to make sure that you have registered the sharp finishing lines of your preparation. You should examine to see if you have all the other details on the occlusal surface and the boxes, and that there are no tears, and make sure that you have a complete mix of rubber. The temporary crown is fabricated using a plastic wafer that has been pressure formed on a study model. This plastic wafer is tried in the mouth, and if it does fit, then we will fill it with Duralay, lubricate the teeth, and have the patient then close down on this. And when this starts to harden or get warm, then this will be removed from the patient's mouth and then allowed to continue polymerization on the benchtop or in a cup of warm water, and then it'll be trimmed and cemented. Before the patient is dismissed, we will need to take an occlusal registration. This is most readily done and most easily done using Duralay on the occlusal surface of the tooth, and then have the patient close into the soft Duralay coping, giving us an occlusal registration of the opposing tooth. By using this and then hand articulation of the rest of the arch, you will be able to mount this very accurately. Now the polished temporary crown is tried in the mouth, and margins are checked just as you would check a finished bridge. The occlusion is checked to make sure that is correct, and then this will be cemented with a zinc oxide eugenol sedative cement. By having the patient bite down on the plastic wafer or form, the bridge usually will be about the thickness of that wafer shy of the occlusion. This will be picked up by the thickness of cement in cementing. So once the bridge is cemented, we will have the patient drive it down to the proper occlusal height and then hold it there until the temporary cement has hardened. This will make a very nice temporary and get the patient used to having something in this edentulous space before you put your final bridge in that area. It'll also make a comfortable dressing to the teeth that you have prepared and removed lots of enamel on. All the requirements of a finished bridge should be followed on this temporary bridge. Now, after the bridge has been fabricated in the laboratory, the patient returns and the temporary bridge is very carefully removed. And it's important to remove all the temporary cement because this can hang up your castings and give you a false reading as far as occlusion in your margins. Careful examination of this bridge before cementing is very important. You should be able to have a pretty good registration of working and balancing and occlusion on this bridge. Your margin should be developed so that you should be able to go from tooth to die and not pick up any catches on the die. And if you have an accurate impression, then this should fit exactly the same in the mouth. You should have about 1 millimeter of space under the pontic so the patient can readily clean. In this particular case, we have sandblasted the occlusal surface so we can pick up any occlusal registrations that are out of place. Also, the sandblasting does give us a dull surface that does not reflect gold and is probably a little more desirable than the shiny gold. We have polished the undersurface and the solder joint area so that this will not collect plaque and it'll be very easy to clean. You'll notice that the castings are clean. There's no investment, no bubbles. The periphery of this casting on the bridge is very shiny, polished to a very high luster. The occlusal surface is sandblasted. Now the bridge is taken to the mouth and very carefully seated. I'll push it down. If it's going to hang up, it may be on the contact on the mesial portion here of this bridge, and that should be very carefully checked. When the bridge is seated, you should check it with an explorer, a sharp explorer, to make sure that the margins are good. And you'll note here that the margins have given us the same adaptation here on this natural tooth as we had on the dies. Now we'll find that very often that the occlusion will change, even though that our bite registration was accurate. The patient wearing the temporary bridge for 3 or 4 weeks while you're fabricating the bridge, the temporary bridge will wear and the opposing teeth will extrude down just a bit, and you will have some adjustment to make on the occlusal surface. In this particular case, we are using the articulating paper to pick up the prematurities. Now they have been adjusted, and now we are seating the bridge back again to check the occlusion finally before we cement. Now we're checking this with a shim stock, and this Mylar shim stock is a very accurate way of checking occlusion, and we will place this on the occlusal surface and pull, and we can determine the areas where we are getting occlusal contact and where we're not. Now the anteriors did not have occlusal contact before we started the bridge, and we will not have it at this particular time. The cementation procedure is the same as cementing an inlay. In this particular case, we are using a zinc oxide eugenol EBA cement, and the bridge has already been filled with the cement, and we're applying it to the tooth. The bridge then will be placed on the teeth and very carefully pushed down to make sure we're in the right line of draw. And once we have this in the mouth where there's some moisture and there's warmth, we have to move pretty fast because the cement does then set up rather quickly with moisture and heat. We're using an orange wood stick to push the bridge down, and then the cement is wiped away from the margin, and then we will again push it down until no more cement will come out from under the bridge and around the bridge margins. It is very important also, before the cement completely hardens, to burnish the margins back to the enamel surface. The hydraulic pressure of the cement oozing out of these margins tends to open up the margins, and with this 5S burnisher, you should try to get to as many of the margins as you can to burnish them down back to the tooth surface. The bridge is being held now with a coolie peg to keep it under pressure while we are cementing it. The margins can be adjusted with a sand disc, and after the cement is hardened, it's important to clean all the cement away and to take the areas where there are marks from the burnisher and polish it with a little bit of pumice. Make sure that all the cement has been removed from under the soft tissue and in the contact area. The cement can act as an irritant, just like calculus, and cause gingival problems. It's important to clean this area and then instruct the patient on the use of dental floss under the bridge to make sure that this is kept clean, and you've made this surface very shiny and smooth so they can remove the plaque, and it's important that they do this at least once a day to keep this bridge clean. A final check will be made on the margins to make sure that We have all the adaptation that we need, and we have the clearance under the ponic. The occlusal surface and the margin should blend in harmoniously with the rest of the teeth in the oral environment. If you have fabricated this bridge properly, then the occlusal registration, occlusal pattern should be correct. The patient should leave feeling as if that bridge is part of them and is not a foreign object. And the bridge should give them many years of good service, providing they give the bridge the necessary home care, and you have them back for recalls to check the occlusion and to check on wear and to check on oral hygiene.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.